Hi, everyone. Thanks for joining us for the Cleft Palate Craniofacial Journals podcast and video recording. And I'm really honored and happy to be the host, your multimedia specialist. My kids make fun of me when I give them that title because they know I'm completely tech unsavvy, but thanks for joining me. And I'm Pat Chibbaro, pediatric nurse practitioner. Retired from the team at NYU, but still very active in this amazing American Cleft Palate Craniofacial Association. So thank you so much for joining me. And I wanted to talk about this paper today because I felt very fortunate on the NYU team that I had a geneticist and a genetics counselor part of my team there ready. But we know that a lot of teams around the country still don't have that kind of immediate access and resource. So I was really happy to see this paper. And let me give you the details. It's genetic testing in craniofacial care, development of algorithms for testing patients with orofacial clefting, branchial arch anomalies, and craniosynostosis. This is a West Coast consortium. The authors are a combination of pediatricians, geneticists, and genetic counselors, and they are Emily Gallagher, Penny Chow, Maria Mills, Hazel Perry, Allison Tam, Glenn Rosenbluth, Yvonne Gutierrez, Jessica Clanmod, Shamshani, Marissa Matthews, Daniela Schweitzer, and Anne Hing. And I'm happy to have Maria Mills here with me, who is a genetic counselor. Maria, thank you so much for joining me.
Of course, it's a pleasure to be here.
So this paper was originally something that I think it was online first, probably about a year ago, and now it's in the October issue of the Cleft Palate Craniofacial Journal, something that you have been working on for a few years. Before we get into it, maybe just let us know what teams this paper has come from.
Sure. Yeah. So I'm representing the Seattle Children's team. I'm a genetic counselor on the team at Seattle Children's Hospital. And then we also worked with experts in craniofacial centers at 3 other institutions, UCSF, UCLA, and CHLA as well. So this paper is kind of a combination of those 4 institutions and multiple team members from each institution. On each kind of regional center team, we had a craniofacial pediatrician, a geneticist who sees craniofacial patients, and also a genetic counselor who sees craniofacial patients.
So I always love seeing these group efforts, and because I just think it brings so much, it makes it so rich. But I'm sure it also comes with challenges as well when you're working with this big group, and maybe we can talk about that a little later. But first question, and I almost always ask this to the authors, is what made your group decide to take on this project? Because it's a big project. There's a lot of work.
Yeah, and I think just for context as well, I have been at Seattle Children's Hospital about 4 years, and when I joined the team in 2021, this project was already underway, so I kind of hopped on a project that had begun a little bit before my time with the team. But from my understanding and from our conversations, I think this project, the idea of designing algorithms for genetic testing for common craniofacial indications, this idea kind of came from um, craniofacial teams where pediatricians may not work closely with a genetics team, for example, and so maybe a little bit more focused on figuring out what genetic testing their patient might be eligible for, or even seeing if a patient with a common craniofacial indication, if genetic testing would be recommended as kind of a blanket statement for them as well. I feel like for many craniofacial indications, for example, isolated cleft lip and palate, the majority of that, of course, is not due to a single genetic syndrome. If we run genetic tests, we often don't find anything conclusive. And so I think this project was kind of the genesis of it came from like who in the craniofacial center might benefit from genetics evaluation first, and second, if they do benefit from genetics evaluation, what would be an appropriate test to order. I most of the teams that were involved in this project have genetic services as part of the craniofacial team. So I think that was also kind of a bit of a bias of our group, was that we obviously had genetics professionals working as part of designing this algorithm, but really we were trying to develop it so it could be used by someone who may not be a genetics professional but sees patients with craniofacial indications.
Right. No, I mean, I think it's so important that you've worked on and put these algorithms together, especially, for those teams that don't have those immediate resources. And as I was reading it, I could see that, this is something that's developed over time. Maybe you can walk
Mhm.
us through the story of this, getting
Yeah.
to the point and then go from there.
Sure. Yeah. I think it was, like I mentioned, it kind of was originally designed. The algorithms were kind of the original idea for this project, and the teams from the four institutions got together, typically on Zoom or WebEx, to meet. And the way that the algorithms originally were designed were that the LA group was assigned one category of craniofacial conditions, the Craniosynostosis algorithm. And so their group worked collaboratively to design that algorithm. The UCSF group designed the Clefting algorithm, and then the Seattle Children's team designed the Branchial Arch algorithm. And so each institution slash regional center kind of took a algorithm to take point on, and then we all met together to kind of provide feedback and improve the original kind of pilot of the
Mhm.
algorithms. And that's kind of the point that I hopped on this project in. I think when I joined the Seattle Children's team, I quickly got involved in this project because I worked closely with Ann Hing, craniofacial geneticist, and then Penny Chow, who was another genetic counselor at Seattle Children's in the group. And they got me involved quickly in the project. And I think when I joined, there was like a first draft of each of the three algorithms. And we were all meeting several times to improve them and kind of design. So that was the original kind of first line pass. The second was that we wanted to actually, after getting feedback from all of the teams and making improvements, we wanted to see how the algorithms actually worked in real time. Like, were they something that could be applied in clinic to patients who may have had unknown diagnoses? And we also wanted to kind of do a bit of a retrospective review of how if they would work effectively to get to a diagnosis for patients followed in craniofacial centers who had a known diagnosis.
Right.
Um, for example, each of the four centers kind of did a bit of that study where we ran patients who had been seen in the craniofacial centers through the algorithms to see, one, if we got to the accurate diagnosis. And then the other thing we were tracking as part of that pilot study was seeing how many genetic testing steps it took to get to the diagnosis. In the
Right.
algorithms, there are often multiple boxes. For example, first consider chromosome microarray, and if that's negative, next proceed to, for example, exome sequencing. And so if a patient would have been missed on microarray but diagnosed on exome sequencing, that would have been two steps to the diagnosis. So those were the main things that we were tracking for patients with known diagnoses as part of our pilot study. The unknown diagnoses category was a little bit more just if the clinical providers agreed with what the algorithms were recommending. For example, is the algorithm recommending what you would actually offer and counsel the family on in real time, or is it recommending something kind of outdated, or is a test being offered in clinic that's not reflected on the algorithm? So that was the main purpose of that trial. After that, we of course revised and there were some changes made. And then the third kind of step in this process was presenting at ACPA in 2022. We presented the three algorithms with some background and gave examples of patients who kind of the algorithms would apply to. And then we did get some audience feedback and kind of discussion based on presenting the algorithms. A lot of our feedback was kind of maybe reflecting the fact that we needed to add context into the algorithms about what different genetic test types might be or look like for people who may have had less genetics background. But that was kind of the third phase of our project. And then we did final revisions and worked on the manuscript.
So it's now in the October 2025, this
Mhm.
paper, and I know that, whenever I read papers that I see have been, going through a process over several years, I have a couple of questions. The first is, for those teams that don't have that resource right on site
Mhm.
with them,
Mhm.
where are these? How easily or how do they know that these exist? Besides reading this paper, of course. Is it something that each team is aware of? Is that something that's sort of been pushed out to these teams?
I don't think there has been a widespread distribution of the algorithms necessarily. I think that's something that for was kind of a secondary goal of our presentation at ACPA a couple years ago, was to like also bring awareness that these were in process and designed. But I think distribution is always a little bit of a black box. It's hard to know who exactly is accessing the algorithms or how they're being used. I think
Right.
the other thing that I would just add, you bring up, it's been a bit of time since the original algorithms were developed. And as we all know, testing technologies and genetics evolve pretty rapidly, as
Right.
do cost of testing, insurance coverage of certain genetic tests. And so I look back at the algorithms and think there could be a future project to update or redesign just based on some advances in genetic testing technologies. Um, I think overall, I look at the algorithms as well as clinical tools. They may not apply to every single scenario, but I think our team honestly still routinely will reference them if we are seeing a patient that, let's say, has a certain suture for craniosynostosis that we haven't seen commonly or haven't seen in a while. We might, as part of our kind of prep to see that patient, pull up the algorithms and say, okay, what is the algorithm recommending? Would we agree with that?
Right.
Um, but I think it's a situation where there's no one perfect genetic test, and what genetic tests we have on hand change all the time. So a future kind of update, I think, to the testing algorithms may be helpful.
Yeah, I mean, I can tell you because I started way back in the day. I mean, it's just changed tremendously what
Oh
was
my gosh.
available.
Yeah.
Total explosion. And I guess one of my other questions was, it was always a challenge for some of our families in terms of not so much the access to what was available at that time, but
Mhm.
the insurance coverage. And I wonder, has that changed? Hopefully in a positive way over time, because that I remember that being a challenge when we wanted to offer certain testing, and then the
Mhm.
parents said, I we can't do that, and I felt badly because I was sort of offering them something that they felt that they just couldn't afford, and then they would feel guilty because they couldn't, parents want to give their kids everything. It was a bit of a dilemma. I wonder
Absolutely.
where is it at now? Or do you know?
Yeah. I think that's such a great question, and that's something that certainly does not necessarily make it into our article on the algorithms, but is such an important component of clinical care that for those of us who see patients is a very real part of daily conversations. What's
Yeah.
the pros and cons of this test? And cons are often cost and insurance coverage. Different institutions have different policies. So I'm most familiar with my own institution's policy, which currently is to do insurance pre authorization for every single genetic test that we order. That way, families have a more accurate idea of what they might owe out of pocket before we actually send a really expensive genetic test. And
Yeah.
genetic tests can be still very expensive for exome and genome sequencing. If insurance didn't cover anything, those tests could be $4,000, $5,000, which
Yeah.
for many families is an extremely preventative cost. So we would not send that test if it was going to be that much out of pocket. Um, Other institutions, again, I'm less familiar with their specific policies, but other institutions get around the pre-authorization by having the lab directly bill families, and oftentimes genetic testing labs will have um, kind of sliding scale
Right.
coverage or a patient out-of-pocket maximum, and so
Yeah.
that can kind of help get around the cost for genetic testing. Overall, big picture, I feel like, as you know, genetic testing has gotten less expensive over time. For example, a single gene test used to be, $1,000 or more, and that cost has come down. Now we're ordering panels or more broad genetic tests that are comparable in cost to that. But one thing that I think is so again, like a daily part of my role as a genetic counselor is to walk families through the pros and cons of testing and talk about insurance coverage and cost for whatever genetic test is on the table. Um, I think that's a difficulty for teams that may not have a genetics professional just simply because of time and kind of like there's so many genetic tests as well, like familiarity with different genetic tests at different labs, which have different costs. So I think it also is a bit of I see it as a part of my role that's beneficial to the wider team, and so other craniofacial centers might benefit from genetic counseling services because we can really walk through families through those elements that take some time but are very crucial and important to
Yeah.
families as well when considering genetic tests. The other thing that kind of goes hand in hand with this pros and cons list in my mind as well is just the potential for uncertainty with genetic testing. There's no perfect genetic test. There's no guarantee of getting back an answer or diagnosis on genetic tests. And especially as our testing technology gets more broad, we often find uncertain variants or differences in the DNA that may or may not be related to their child's craniofacial condition or an unrelated health problem. And so that's one other thing that we often talk about with families that kind of doesn't make it into this paper is like, what is families' temperature on uncertainty? How broad might they want to go? Are they wanting the most accurate recurrence risk counseling for future pregnancies? Or are they really just trying to get to medical actionability for their child? Like, does this change my child's medical care? I think all of those priorities are kind of something that weigh into deciding if genetic testing is appropriate.
I think that is such an important point, is really taking, as you said, taking that temperature of the family and knowing how much, how much do they want to know? Because for some families, and I found this even when I would be doing a prenatal consult, for
Mhm.
example.
Mhm.
So we know that the baby has a cleft lip. We don't know the full extent until the baby's born, right? And I had, created an entire timeline of all the possibilities of what treatments and surgeries a child would need. But one of the things that I learned in working with the families was to ask them in advance, where are you at? How much do you want to know right now? And for some families, they would say, I only know, I just give me the first year. Say if it's a cleft lip and palate, just give me all the possibilities for the first year. And others will say, I want to know everything until my kid's in college and everything in between. And I think that's it's important to really, to be really understanding where that family is at. So that was a really great point that I think you made about that. Really appreciate that point. Definitely. I've learned a lot. I've learned so much from parents over the years. I had one other question, which is the algorithm itself. Is that something that you actually review with parents? Is that something that do you think would help them understand why you're recommending something or what your process is?
Yeah, sometimes we certainly do. I would say it's not every patient that we review the algorithm with, but for I think sometimes it's helpful to review even for patients who may not be where the algorithm might recommend no genetic test. It's helpful to show, for example, like for single suture, sagittal craniosynostosis, where there's no family history and the child is otherwise healthy and development is typical, like just outlining kind of our steps of how we got to most likely no genetic test as a recommendation, and kind of some of the algorithms as well have empiric recurrence risk estimates on them as well. So that's something that we certainly have shared with family as a
Mhm.
resource. Oftentimes, if I were to, like, in a genetic counseling session with a family, run through the algorithm, I would kind of walk through, like, this is talking about orofacial clefting, and your child is here where they have cleft palate without other anomalies. And so that
Right,
makes us think about this genetic test.
right.
Yeah, so it can be a counseling tool as well. I think it's something that, again, doesn't always come up in every session, but is
Mhm.
sometimes helpful to outline how we even got to a genetic testing recommendation.
Yeah, I think again, I think it's for some families, that visual is something
Mhm.
that really just, helps them understand better, and they feel like, because I always feel, I feel parents have said over the years, one of the things is we feel this lack of control, and I think the
Mhm.
more information that we can give them about why we're deciding to recommend a test or a treatment or a surgery, I think just also really helps to solidify that relationship of you with that family. So, that's, and those are the things I thought about as I was looking at this paper, and how important this is for families to really to get that kind of a visual for some of them, for some of them,
Yeah.
you
Yeah,
know.
absolutely. I think it also helps, I think just speaking from my own clinical experience, it helps to kind of have um, the experience of, like, oh, okay, this is a common craniofacial indication. Let's say it's like coronal craniosynostosis. This is what
Mhm.
we do for this indication. But that kind of like shortcut in my mind is often not for families. This may be the only instance that they've ever heard, the first time that they're hearing about craniosynostosis, and so they don't necessarily have that background and context. So I 100% agree that it's helpful to walk through the reasoning, and I think that kind of is, again, something that we often talk about with families in our genetics clinic is, like, what are you hoping to gain from this testing? And, like, what are the chances, what are the yields that we might have of getting back an answer on a
Right.
genetic test that might change your child's medical care, for example. That's something that I think we did try to highlight in the article, was just that genetic testing can be helpful for families learning why their child was born with a craniofacial difference, or for recurrence for future pregnancies, but also specifically that some genetic test results and some genetic diagnoses are very medically actionable, in the care of a child, such as planning for surgery. In the
Right.
case of a child with 22q deletion syndrome, if that diagnosis is missed, that could have very real medical implications. And
Right.
so that's something that I think we tried to highlight in the article, because it's an important reason why genetic testing in craniofacial care is is important for patients with some craniofacial differences.
Definitely. So before we wrap up, I always like to ask my authors, what advice might you have for someone who's maybe just embarking on doing research
Oh,
in this
man.
whole craniofacial world?
I feel like I'm just embarking on doing research and I'm the one that needs advice, but I think I think one thing that I have been trying to learn and practice myself is just that my role currently is mostly clinical. I see patients in our craniofacial center, and I have many project ideas, and our team has many project ideas that I would love to work on and implement in terms of research. But carving out that space and time, I think, is something that has been hard for me in the past.
Mhm.
I think at first, when I began working in doing a little bit more craniofacial research as part of my role, I had the mindset of, okay, once I finish every single thing I have to do for patients' clinical care, then
Right.
I'll work on this project, kind of
Right.
like on the back burner.
Yeah.
And as we all know, that never happens. You never finish everything on your list. And so I think um, if research is important to you, carving out that time and blocking your calendar, or kind of closing your email for a certain number of hours, is really important to actually be able to make measurable progress on projects. And again, that's something I'm still trying to learn myself, but that would be my little piece of advice.
I think it's great advice. I think it's really, I think that that is the big challenge is having, and I've heard it over the years from those in so many different specialties is, carving out that time. But I really appreciate this paper, and I think it's so important for, especially for those teams who maybe don't have the kind of support and resource that your teams did and some of the others around the country. So I hope that that everyone reads this paper. And let me just introduce it one more time, and you can find this paper in the Cleft Palate Craniofacial Journal in October 2025 issue. And the paper is Genetic Testing in Craniofacial Care, Development of Algorithms for Testing Patients with Orofacial Clefting, Branchial Arch Anomalies, and Craniosynostosis. And the authors, a combination of genetic counselors, geneticists, pediatricians from Seattle Children's Hospital, UCSF, CHLA, and UCLA. Did I get it right?
You got it exactly right. And
And
huge,
and
huge shout out to the team. Yeah, it was a very collaborative effort. This
yeah,
project would not exist without everyone who was involved.
well, that's why it's as rich and as it is. And the authors are Emily Gallagher, Penny Chow, Maria Mills, Hazel Perry, Alice and Tam, Glenn Rosenbluth, Yvonne Gutierrez, Jessica Shamshoni, Marissa Matthews, Daniela Schweitzer, and Ann Hing. And Maria, thank you so much for taking the time to share your thoughts and educate us about this paper and the importance of the work that all of you are doing. It's so, so important. So I really appreciate it. Thanks so much.
Of course, it was my pleasure. Thank you.
Okay, take care, everyone.